In Essential Task 910, we are going to transition into the treatment portion of our unit on clinical psychology. Today, we're going to talk about a category of treatment methods known as insight therapy. I recommend vertical for today's concept map. As you can see, we're going to be talking about 5 separate boxes in what I consider a very vertically aligned concept map. I'll allow you to pause the video here, though, before proceeding into the concept map. We'll start all the way at the top. The word insight is actually a term that came up in an earlier unit, specifically in our cognition unit. The word insight itself in isolation means the aha moment when the solution to a problem suddenly dawns on you. Maybe after struggling to fix your computer, you took a break for an hour and then all of a sudden a new idea popped into your head. That's what the word insight means in isolation. However, when we use it in the context of therapy, we're actually going to be talking about a therapy that's designed to encourage aha moments with your patient. The first term here is psychotherapy within the definition, just so that we know what that means. That means a therapeutic technique based on some type of psychological principle. So the term psychotherapy is a term that we're going to use a lot over the course of the remainder of the unit. Insight therapy is a type of psychotherapy, so therapy predicated on psychology-based principles and ideas. And as I mentioned a moment ago, it's designed to trigger those aha moments. The underlying idea here is if a patient says something along the lines of, now I understand my symptoms more, now I understand the root cause of my anxiety or my depression symptoms or these personality disorders. Well, hopefully that in and of itself can help reduce symptoms, because when you become more aware of your symptoms, or at least the underlying causes, at least according to insight therapy, that might be sufficient for a reduction in symptoms. There are 2 types of insight therapies that we're going to talk about. The first is predicated on psychoanalysis through a process called free association. Psychoanalysis, when we see this term, we need to immediately think of Freud and Freudian principles. Then we're going to talk about what's called client-centered therapy. The first form of insight therapy is known as free association, and just to give you a zoomed out look, it falls under the category name of psychoanalysis. Psychoanalysis is the blue color-coded column in my classroom. It is the color-coded column exclusively devoted to Sigmund Freud and Freudian followers. Whenever you see this word psychoanalysis, you need to immediately think of Freud. And when we think of Freud, the key word, and it's bolded in the definition here, is unconscious. Just to give you a quick refresher, Freud believed that our personality is a reflection of unconscious drama between our id, our superego, and our ego, and that in some cases, the id or the superego might be able to overpower the other, and that our personality is a reflection of that unconscious inner drama. Well, when we take that concept and apply it to therapy, we come with the idea known as free association. It's a psychoanalytic approach to therapy in which patients relax and freely say what comes to mind. In theory, over time, once there's a built-up familiarity between the patient and the therapist, and this in some cases might take a considerable amount of time, the patient begins to express thoughts and ideas and feelings that branch into the possible root causes of their symptoms. So, for example, after enough familiarity has been built up, maybe the patient starts to talk about unresolved childhood trauma. Maybe they talk about the relationship with their parents, maybe the relationship with their mother or father or guardian, maybe some type of bullying that they experienced as a child. And hopefully by doing so, the therapist is able to identify precisely what might be causing the symptoms of the clinical disorders that we've talked about in the first portion of this unit. It's the idea that if you were given the opportunity to freely express whatever comes to mind, eventually you will display thoughts based on unconscious inner conflicts. And once we start to identify those unconscious conflicts, and we start to see those reflected in the discussions between the therapist and the patient, that in and of itself might be beneficial, because then we can pinpoint precisely the root causes of your symptoms. And again, this whole essential task today is about insight therapy, triggering aha moments. Maybe if in the context of free association, uncovering the source of your symptoms being related to, for example, unresolved childhood trauma, that might trigger an aha moment in a patient who says, wow, I never realized how much the unconscious conflict unresolved regarding my parents is actually affecting me now with, for example, the anxiety that I'm experiencing. To go into more depth in terms of how free association works, there are some specific components of free association that psychotherapists who are psychoanalytically oriented, so therapists who practice this principled psychoanalysis technique, are trained to look out for. The first is resistance, and sometimes it might take weeks, months, if not nearly a year plus, to find a moment where a patient really exhibits this, but it's really critical if you're going to approach therapy from a psychoanalytic perspective to be trained to hear moments of resistance. Resistance is when a topic comes up and a patient simply resists talking about it. And that's a big deal. For example, if in the means of this free association, finally the topic of parenting comes up and your patient is unwilling to talk about it, that is a moment of resistance. That might be the source of their symptoms. That might be some type of repressed trauma that they've been unwilling to disclose. And that's critical because now when we've identified these moments of resistance, it's the therapist's responsibility to then interpret, why are we resisting this topic? Why are we unwilling to talk about your parents? Or why are we unwilling to talk about your schooling experience? Or why are we unwilling to talk about this traumatic experience from your youth or your childhood? And once we identify these moments of resistance and interpret what that might mean in relation to your symptoms, that in and of itself might allow the patient to come to terms with and understand their underlying symptoms more, trigger that aha moment. Oh, I never realized I've been resisting this topic my whole life, and being able to talk about it in this format has really helped my symptoms. The third one is not a guarantee, but it was actually quite common for Freud in his work to find examples of what's called transference, and it's another behavior within this type of therapy that a psychoanalytically oriented therapist is trained to look out for, and it's moments of transference, and it's a big deal. Transference is when the patient takes emotions that they might associate with a past experience, for example, a previous romantic partner, maybe a parent or guardian, or virtually anyone, and they take those emotions about that topic or that person, and they exhibit those emotions towards their therapist. They project those emotions towards their therapist, to use the proper terminology. So, for example, let's say you had a traumatic upbringing with a parent that did not provide you with the nourishment and support that you would have liked, and you really wish that that parent would have done that. And you might have this unconscious, unresolved conflict pertaining to your parents. And now, in the midst of therapy, after, let's say, a year of therapy, you start to exhibit feelings of affection towards your therapist. You tell your therapist that you love them. The therapist then must take a step back and say, what you are doing is taking the emotions that you wish you could project towards your parents, towards your mother or father, whoever it might be, and associating it with me because I have been the person that has begun to talk about these past experiences. This feeling of affection is not really truly genuinely for me, your therapist, but is actually a reflection of how you wish you could have felt, or maybe that you do feel towards this sensitive subject matter. There are numerous circumstances where talking about significant others or family members where patients express feelings of affection or even anger towards their psychotherapist, towards the psychoanalytically oriented therapist that might not necessarily be genuine on the surface. Like, for example, if you've spent a year and a half talking to your therapist about these really frustrating subject matters throughout your life, you might by 18 months start to curse your therapist, tell them that you hate them, tell them that you've had no value, that this has been a waste of your time, when in reality, you're taking the anger that you have associated with these topics and just projecting it towards your therapist, because the therapist is the person that in a modern context, current today, is talking about these really sensitive subject matters from a past experience. So it can go in both directions, transferring love, transferring anger, but it's really important to note for a therapy perspective, from the therapist's perspective here, to take a step back and acknowledge that this could very much be transference. This might not be a genuine feeling towards you, the therapist, as opposed to something that is linked to an experience in the past. So this is what free association would look like. Sometimes free association through this psychoanalytic perspective can take a year plus to actually effectively alleviate symptoms. There are some individuals who see their psychotherapist utilizing this technique for years and years, because getting into these subject matters just the first time can take a while. And the whole purpose of this is for the constant dialogue to be there, for the therapist to constantly listen out for moments of resistance. And it might just simply take a long time for those moments to occur. But once that resistance has happened, once the interpretation has happened, once even the interpretation of transference has happened, hopefully the patient has this aha moment where they acknowledge and understand why they are experiencing their symptoms as an adult, or maybe as an adolescent or teenager. And then we can use that aha moment of understanding your symptoms as a means of alleviating those symptoms in the first place. Transferring over to humanist therapy. Humanism or humanist therapy is actually another one of the color-coded columns in my classroom. It is the yellow color-coded column. Fresh reminder, humanism, when you see this word, simply put, the most simple definition, is a theory of psychology that emphasizes personal growth. It's all about why are you progressing, or why are you being impeded? What is stopping your personal growth? And one of the primary theories back when we talked about this was Maslow's hierarchy of needs, that pyramid structure with self-actualization at the top when you become exactly what you wish to be, and then perhaps why it is that you're stuck along that hierarchy. Are you stuck in esteem? Are you stuck in physiological needs? Are you stuck in safety? Where are you stuck along that hierarchy of needs that's impeding you from reaching your personal best of self-actualization? All about personal growth. Well, humanist therapy or humanism-based therapy is all about allowing patients to gain insight, so aha moments, as to why they are not growing. What is stopping them from reaching self-actualization? What is stopping them from reaching their perfect self? What is impeding their personal growth? A lot of self-help in group therapy is based on humanism. So we're talking about things like groups for, let's say, Alcoholics Anonymous, for example, or other group therapy sessions where a lot of people are talking amongst each other about a similar topic, about similar symptoms, perhaps of similar disorders or behavioral patterns. And doing so can sometimes allow you to get that insight into what is stopping you yourself from growing. Perhaps that's not drinking as much or not using certain types of drugs as much. Well, that type of therapy session is very much predicated on this idea of allowing patients to understand what is stopping their progress in their own personal growth. Doesn't always have to be in group therapy, though. There is a technique proposed by key psychologists. There should be a key psychologist icon here. Carl Rogers. It's often called client-centered therapy, though some people call it person-centered therapy. So be wary, it could be called either client or person-centered therapy. The idea of this Rogers-based therapy technique is predicated in humanism, and it's the idea that if a therapist exhibits what's called unconditional positive regard towards their patients, that will help their patients grow. Because typically, when individuals begin to talk about sensitive subject matters like maybe excessive drinking or binge eating or really virtually anything from this unit or almost anything in life, there are just some subject matters that are really sensitive, and people naturally feel like when they talk about them that people might be judging them. Well, that's not the case with this therapy technique. Unconditional positive regard is the idea of being as accepting and non-judgmental as humanly possible towards your patients or towards your clients. So, for example, you might have a patient that admits to doing something that by and large culture would consider a terrible mistake. Drinking a lot, maybe getting into an accident because of it, maybe getting your license suspended, maybe episodes of binge eating, something that by and large society unfortunately might judge. Well, that's not the case in this therapy session. When you're exhibiting unconditional positive regard, regardless of what your patient tells you, you need to be accepting, caring, and non-judgmental, and it needs to be genuine. You can't just fake it. You really need to exhibit this. If a patient or client feels like they are actually being accepted in this environment, the patient might be more willing to delve into these subject matters that for much of their life they've kept to themselves because they felt like they were constantly being judged. If you can really come across and exhibit this unconditional positive regard of being truly caring, it might allow you to delve into subject matters that are really sensitive, and now the patient can experience that insight and growth because they can really delve into why it is that this behavior has been persistent in their life, why it is that they're not progressing and improving and growing as a person, and then maybe walk away from therapy having actually gotten into subject matters that for most of their life they felt unwilling or uncomfortable talking about. Because at the end of the day, unfortunately, most people feel like they experience what's called conditional positive regard, where, of course, I love you, or of course, I care about you, but if you tell me these horrible mistakes that you've made, there might be that asterisk to it. Unconditional, the term at the top, is the complete opposite. There's no judgment. It differs from conditional positive regard because under conditional positive regard, what, for example, this patient might feel like they often experience, there are criteria. There is too much that can be done. There are mistakes that you could admit to that would cause judgment. And if that's the environment, if that's where the dialogue is happening, patients might be unwilling to talk about some of these sensitive topics. Another example outside of therapy of conditional positive regard, not that you would ever say this, but perhaps one might say, of course I love you, as long as you get good grades though. You don't get good grades, that's a different story. Well, that's conditional positive regard. There is a condition by which you exhibit this positive regard. That would be, of course, conditional, as opposed to unconditional. I love you no matter what, or I care for you no matter what, or I'll hear you out and not judge you no matter what. If you can exhibit that non-judgmental attitude with a patient, as I mentioned a couple times, that patient might be willing to delve into some really sensitive topics. And for some, it might be for the first time. Last part, the last box in this essential task, is to acknowledge a technique that is exclusive to humanist therapy, that you will really only see with this client-centered therapy. And it differs a lot from the type of techniques that we're going to talk about later this unit. It's called active listening. Active listening is a technique where the therapist is able to really carry on a conversation with very minimal interruptions. Sometimes a conversation requires a statement by the therapist to push the conversation in one direction or another. Even in this technique, that's sometimes necessary, but with active listening as a underlying technique within the client-centered therapy approach, it's really pivotal to minimize that. The only goal really of active listening is to confirm statements or the feelings of your patient and then reword them. So often what that looks like is the patient might say, I've been drinking excessively this last month. And then the therapist should then say, so you're telling me you've been drinking more than you would like this last month. Well, the therapist didn't really add a whole lot to that. They basically just took what their patient said and reworded it. What that then does, though, is it carries on the conversation a little bit, but it puts the onus back on the client or the patient. And the patient might say, yeah, I feel like it's been 4 or 5 times a week, and I really don't want to do that. I really want to minimize that. Well, what you did there is by just rewording almost exactly what the patient said, it allowed the patient to then push the conversation on their own behalf further. And the more you can go back and forth and do this, you can basically carry on a conversation without interruptions, without the pushing forward of trying to say, well, this must be a byproduct of this thought that you have. You're not really drawing conclusions. You're not doing that interpretation of the psychoanalytic approach under free association. And oftentimes this involves even a lot of nonverbal cues like head nodding. So if you're sitting there and you say, so you're telling me you feel like you're drinking too much. I see. That head nodding, that shaking of the head. Okay, yes, continue. That's really pivotal because it shows that you're listening. As the name suggests, you're actively listening. And you're doing very minimal interruptions. I would like you to watch really all of the clips attached here under all of the sections. For the clip up here, you only have to watch about the first 5 minutes. Otherwise, all 4 of the other clips are worth watching in their entirety. This one, and then honestly, either of the 2 down here worth watching that would give you a good encapsulation of some of the techniques that we're talking about here. But regardless of which of the 2, the underlying objective of psychoanalysis through free association and humanist therapy through the client-centered approach is for a patient to walk out of the therapy session having a better understanding of what causes their symptoms, trigger that aha moment, whether that's by interpretation and resistance, and in some cases, interpreting transference, or by active listening and exhibiting unconditional positive regard and allowing a patient to get into subject matter which under normal circumstances they feel judged or unwilling to talk about.